Hello there and happy Friday. My name is Julie Hirschberg. I am the owner, founder of Re+active Therapy and Wellness here in the Los Angeles area. And so happy to see you and to chat about some of my favorite things, some of our favorite things at Re+active. And one of those is functional movement disorders. And you probably know that if you join me every week, if you're part of our newsletter where I send out videos and resources every week, you would know that we're pretty passionate about functional movement disorders. And in fact, I think passionate about movement disorders in general, and rare, lesser known disorders that many people struggle to understand in the medical community. I think that's a big passion of ours. We have been studying this, teaching about it, working with people for 12 years in this realm. We actually started our very first functional movement disorder intensive about 5 years ago, and we have been doing it ever since. And so today I want to talk particularly about an article, a research article that really caught my attention. And it's called Integrated Therapy for Functional Movement Disorders. And by the way, it's a free full text article. If you're part of our newsletter, I will send a link with it. If you're not part of our newsletter, sign up for our newsletter. It's just reactiveeducation.com/newsletter. This article is called Integrated Therapy for Functional Movement Disorders. Time for a change, which I agree, it's time for a change. This is by a group in Toronto. The paper lead author is Sarah Lidstone. And I don't know about you, but as a therapist, sometimes I get an article and I read it again and again and again. And this one particularly, it just resonated with me. It really validated my understanding, our practice at Re+active. And I've read this article several times already. Now, what's nice is it's a short little article. It's not like the optimal theory paper is another one I read a few times, but that's because it was so dense. It took me a while to get through it all, and I needed to go back and try to understand it. Not this one, very clear. So I shared a little bit about it on Wednesday in our Instagram live. So again, if you're on our newsletter, you'll see I'll send that out. Our Wednesday videos, our Friday videos. I've highlighted the heck out of it, and I just had to share it with you all. So by the way, you can catch our Wednesday. I shared some nuggets. Particularly, I shared this diagram from the article that showed the limitations of referring and kind of working in parallel versus working together in an integrated way. So you can catch that video. Today, I want to talk a little bit more in depth about what's in that paper. So the background in physiology with the neuroscience that supports this integrated approach for functional movement disorders. The program that the team in Toronto wrote about, the outcomes that they share in this kind of pilot study, and how we take this as therapists, how we're using it at Re+active, I think how we can take it into practice anywhere. So the first thing, let me remind you, if you're just joining us for this video, what is a functional movement disorder? A functional movement disorder is a movement disorder, so difficulty moving, walking, dystonia, tremor, myoclonus, but this functional part of it is it's characterized by involuntary, but a learned habitual movement pattern that is driven by an abnormal self-directed attention. What's important about this is that it is not an isolated or structural neurologic lesion, but it is the overall function or connectivity in the nervous system. So that's what we're talking about when we talk about integrated therapy for functional movement disorders. Now, what the authors note in this paper, these are very common referrals to movement disorders clinics. I've said this before, but this is the second most common reason people report to a neurology clinic. So it's very common. And It, as I mentioned with kind of the definition of it, there's not a clear structural neuropathology. There are clear connection issues, and these come up in fMRI. But they include the abnormal movement. So they might include dystonia, they might include tremor, a gait disorder or weakness, but they also include other things like fatigue and pain, that sensory symptoms that can come alongside of these symptoms. And what I love that the authors did in this is really set up this background. So I told you we would talk background. And they talk through some of what we understand in this more holistic approach, like a more, I would say even beyond a biopsychosocial model, that proposes they're predisposing physical and psychological factors that might contribute or bring on a vulnerability for functional movement disorders. But this happens in the context of a precipitating event or series of events, and maybe even a precipitating psychological state. And the functional imaging, the functional MRI imaging, point to some of these interactions. So abnormal motor and limbic, so limbic being some of our emotional circuitry in the brain, abnormal motor limbic interface. Deficits in sensory motor integration and agency, where we feel control of our movement. So this really highlights that we can't just treat one part of it. Like, we can't just treat the motor part and expect it to get better, because it's coming at the interface of all of these systems. So sensory motor, autonomic, neuroendocrine, emotional, all of these are important factors. Now, the authors note, so basically, this is the premise of us needing an integrated approach. If we treat something purely psychological or purely physical, we're kind of dissociating those things that are actually really interconnected in the brain. So they pointed to some of the prior research, we've talked about it before, of interdisciplinary programs. And by the way, a difference from multidisciplinary, where you have multiple disciplines, but they're kind of doing their own thing. Interdisciplinary or integrated is they're doing it together. And they point to a really nice study, Ibeck was the author of this one, where they did a small study, 12 patients, and they did neurology, psychiatry at the beginning and end together, and then an individualized plan of care. And what they found was really nice outcomes long term. So I actually had a patient reach out and say, what are long-term outcomes with this? And I think this is really important to understand. They looked at outcomes 3 years later and found significant symptom improvement. And they found that the majority of these people, for example, were able to work. Whereas people who received just standard treatment alone, 70% of those people were not able to work, which is a large number of people, and that's a high level of disability. So that was one example, and again, kind of how this group built their program off of these examples. So what they did, and again, I'm not in their clinic, but from the research article, I'm sharing this with you. They basically did a little pilot clinic to see if this was feasible. So they had a total of 11 patients. They had, a symptom. One person in the study had symptoms for 20 years, and I think the shortest was maybe about a year. They had a 6-session outpatient biweekly treatment program where they had neurology, neuropsychiatry, and physical therapy in 45-minute increments, and they could work off of each other. Beautiful, I think, just simply beautiful. I think as a therapist, as a PT or OT, speech therapist, and many others in the rehab world, we love working together like this. And one of the things that they noted in these sessions is that as they saw each other, as the person evolved, as the formulation evolved, so did the nature of the treatment. So that's very common. That's what we see a lot when we see people over the course of an intensive, is that they change and we change with them together as a team. So here are the outcomes in the study. So at the program completion, 7 of the 11 of the patients, so 64%, had a very high improvement. So we often will use this scale called a global impression of change, which is really looking at how much you changed over that time. We can rate it as the clinician, the patient can rate it. So the patients rated a very high level, much or very much improved, and that was sustained at 3 months. Spectacular. They also noted that there were people with mild or no improvement. And in looking at those cases, and what I love is they actually wrote up little cases of people that improved and people that didn't improve. Those that had very mild or no improvement had a longer disease duration. They were older in age as well. They also found that some of the limitations there as well was that they had a lot more perpetuating factors, and were still pursuing diagnoses, didn't accept the diagnosis of FMD. That is what we found as well, and that has been shown in the literature many times as well as a limiting factor. It's possible that those people maybe need more than, this is a pretty short amount of therapy, 6 sessions. Maybe somebody with a more prolonged course needs longer sessions. I would argue maybe they need OT too. I really wouldn't do our program without having occupational therapy. But anyhow, I wanted to share one of the little vignettes. They wrote these little clinical vignettes with their different subjects. And it's nice also, again, if you go deep into the paper, you can actually see there's videos with it. So one of the vignettes was with a student. They were 31. They had an abrupt onset of jerks, like a myoclonus in their trunk, with pain and sensory changes after a motor vehicle accident. This is something we definitely see a lot as those kind of initial accumulation of events. There was also some other personal history of a civil war and a lot of violent conflicts, so something else to take into consideration. And they went through a series of treatment, and I like that they explain some desensitization, uncoupling sensory triggers from motor symptoms. They use some cognitive behavioral therapy to target some of the fear with the movements and the disease, and normalizing some of the patterns through automatic movements like soccer, for example. And essentially for this particular patient, his symptoms remitted by the fifth visit. And so that's a pretty strong case to me. And I often like to share with others who maybe haven't seen people with functional movement disorders, and they have people coming to them and saying, hey, do people get better? Like, I love sharing these stories. Yes, people get better. This is how they do it. And I do think it takes an individualized approach. Not everybody's going to be dribbling a soccer ball, right? But this group in Toronto really put together some nice examples of how this was done with really different types of presentations and cases, and had great results and sustained those results 3 years later. Really great. So one of their big conclusions that I really love is this. They said a truly integrated model, like they did, challenges the dualistic notion that the mind, the brain, and maybe it's like a trialistic notion, I don't know, mind, brain, and body are separate, and instead attempts to help patients appreciate that movement, sensory processing, cognition, and emotions are intimately connected. I thought that was such a beautiful statement. That is literally like, oh, that speaks to my heart. That's why we created like a pie chart with all of these pieces to show that they're interconnected. And so that was the conclusion. And I just want to share, this is This is what we love doing at Reactive. So, and I would love to hear from you if you're a healthcare provider also doing an integrated approach, how you're doing it. So we do something similar. We do PT, OT, and psychology. We also incorporate fitness professionals like personal trainers, yoga therapy. We have an interdisciplinary meeting to plan, kind of take the history, plan out which pieces of the pie each person might be addressing, and then we collaborate daily and weekly. We meet as a team to progress and change and evolve with the person. It has been such a rewarding experience. I will say, we're just finishing one of the intensives that I was a part of today, and it was so rewarding to see somebody going from a wheelchair to walking and dancing and moving really confidently, and to do that as a team. So for us, it's PT, OT, and psychology. And yoga therapy is a big part of that team. But we also bring in the neurologists. They're not in our practice, but actually in our last case, we had the neurologist join us for our team meeting too, to discuss some of the key pieces that were happening medically. So I feel just over the moon happy that I have this team to get to work with. And this has been a 12-year process to build this team, to put together a program like that. And we started with just PT. And I think you can still do this with a very strong collaboration in your community, for sure. So that's what we've been doing. That's what we've been learning about this integrated model. Again, if you want to catch that article and these videos every week, sign up for our newsletter. It's reactiveeducation.com/newsletter, and you'll get this in your inbox every Friday. And I almost forgot, so I'll tell you really quick that we also, as you know, we're so passionate about functional movement disorders. We are doing a free webinar on functional movement disorders. This is a first for us, but I'm so excited for it. We're doing it Saturday, September 18th at 9 a.m. It is free. It's for healthcare providers who just want to make functional movement disorders simple. Keep it simple. So we're going to provide a simple framework that you can use to get started, to progress. We're going to take your cases live in that webinar and discuss how we can use that framework and how to make it really simple for you and actionable. So I'll put a link in here. It's reactiveeducation.com/FMD webinar, and that is free. We would love for you to join us. We would love for you to share this with other PTs, OTs, speech therapists, physicians, neurologists that need to learn about functional movement disorders. We want to get the word out. So thanks so much for being a part of this with us. We hope you have a wonderful weekend, and I will see you next week.